Good morning, everybody. I would like to thank the organizers for inviting me to speak to you for challenges for perfusionists in congenital heart diseases. I have no disclosures to make, and my objectives will be to speak about initiation of ECMO in congenital heart diseases, the challenges during the ECMO, the weaning, a bit about the single ventricle lesions and the cannulation, and then a last word about the adults with congenital heart diseases. They were formerly called the good patients, grown up with congenital heart diseases, but they are so long on that we now have even adults, not only grown-ups. And one thing is sure, Roberto already mentioned it, that's not one size fits all, even less in children. We have to have tailor-made. I try to get you through the presentation by some cases. So we have a 5-month-old child. She's 6.7 kilos and she has a trisomy 21. So for those of you who are not doing congenital hearts, this child has an AV canal. This is really not nicely working. So you have a huge atrial septum defect, you have a ventricular septum defect, and you see even the AV valves are abnormal and they need to be reconstructed during the surgery. So this child comes onto the ICU after AV canal repair, and we have left the chest open because we expect some complications and swelling. So we have a high requirement of inotropic needs, and we have arrhythmia problems with the jet. And over the next 6 hours, the situation is worsening. The child barely has any urine output anymore. We have an increasing lactate and a central venous saturation only of 23. So we have a pending arrest, and we make the decision not to wait that the child is arresting, but we go on VA ECMO, and we can cannulate through the open chest with a central cannulation. We put in a 14 French venous cannula and a 10 French arterial cannula, and the flow we achieve is 0.45 liters per minute. So then 4 hours after ECMO initiation, we have this blood gas analysis, which still shows us a very high lactate of 9.4. And we still need inotropic support in the form from adrenaline and noradrenaline to achieve a good mean pressure of 45 to 50. So what's the problem here? We have already heard we shouldn't injure our heart more with inotropic support, but why can't we not achieve a good perfusion pressure for our child here? Well, we obviously have a problem with inadequate oxygen delivery and the consumption. And the reasons for not having an adequate oxygen delivery are numerous. It can be inadequate ECMO support, yeah? Did we choose something wrong? Do we have a bleeding? Do we have a residual lesion? And if we have a residual lesion, how do we address it? How do we manage it? And now my question to you is, I don't know how many pediatric perfusionists are in the room, but is the ECMO flow of 0.45 liters adequate enough for a 6.7 kilo child? Well, optimally, we would like to use the formula. We want to have at least 80 mils per kilo and minute, which would make 0.54 milliliters. But we dial up the ECMO flow. We cannot achieve it for this child. So, of course, we need to ask ourselves, why is that the case? And it's, of course, which cannulas should be used best, and which cannulas can we use in those children? And the question is a 14 French cannula and a 10 arterial, the optimal cannula in an open chest patient. So for our hospital, we have made such a flow chart for VA ECMO, where we have the weight of the children and the advisable cannulas for a chest cannulation. Here you see would be 18 French for the venous cannula and 10 for the arterial. So the cannula chosen was too small to support to get the optimal flow out for this child. So I think it's important to think about this, even if you do it not very frequently, to get you some helps and some easy decision-making tools. Because when you need vasoactive agents on ECMO, you're actually not doing an adequate ECMO support unless you want to have a tiny bit of contractility for the venting, where we come to a tiny bit later. Because the inotropic and chronotropic effects of these vasoactive agents, they don't allow myocardial resting and so delay the myocardial recovery. And the vasopressors have also shown to increase the oxygen consumption via their cardiomeganic properties. So we really need to optimize the ECMO support and provide sufficient flow. So what helps for easier decision-making, especially if you don't do it so often, or you have patients who are frequently in cath lab, like our congenital heart diseases. I always say we repair, but we don't fix them forever. They need to have several cares. We put small conduits, they grow, we have to put bigger conduits. So they are going under different and many procedures, so their vessel status can be quite desolate. So what helps is, for example, having such a bedside drawing where you know which sites you can use for cannulation if you don't have already an open chest. And also cannulation chart on an ECMO card or an ECMO machine can be handy, and we have it, for example, for VA ECMO and also for VV ECMO, which gives you at least an estimation when your cardiac surgeon is standing bedside and wanted to have the cannula handed quite fast. So our next case is a 9-day-old child. She's 3.3 kilos, and after transposition of the great arteries, again, for those who are not familiar with these diseases, I made a little picture here, and you see the aorta arises out of the right ventricle, the pulmonary arteries arise out of the left ventricle. So you swap those two arteries. Looks in this picture very easy because here they are the same size and you just swap them, but also you have to swap those little bastards here, which are called the coronaries. So that can be more challenging, especially in a weight of 3.3 kilos. So also this child has impending cardiac failure, high inotropic support, again a pretty bad blood gas analysis with a pH of 7.1, again a high lactate. Of course, we roll in the team, we are not waiting until the child is arresting, we go on ECMO. I showed you this gas just prior to ECMO, and then we draw another blood gas just when we've gotten on ECMO. And what do you see? Has it gotten better? Nope. Yeah, pH even worse, lactate even worse, base excess even worse. So, what is here happening? Is that good? Is that normal? Is that bad? Do we have a problem? So, do you all know which 3.3 kilos, what we prime those children with? We prime them with blood, blood and crystallate mixture. And this is actually a real blood gas of one of the priming fluids, yeah? You see the pH is 6.7, yeah? You see the potassium is 7.6, the lactate is 23. It's a very, very bad priming fluid we are having here. And this has to do with the RBCs that were used for the prime. Yeah, that were probably very old RBCs, when you have a pH of 6.7. Of course, calcium is always very low in blood products, a potassium of 16, and the lactate so high that our blood gas machine is not analyzing it anymore. So and if you initiate bypass or ECMO in children, you have a really high exchange rate by 100 mils per kilo a minute, and you infuse this in this child. If you didn't have a cardiac arrest before, you certainly will have if you give that to your patient. Yeah. And normally for children, we only say we are allowed a dose of 15 mils per kilo, yeah, to avoid potential adverse effects of preservatives there in the blood product. So we are very cautious what we do and when we give blood products to our patients or children. So the message here is use very young RBCs, always call and say we need the newest blood, what we can have available from blood bank, yeah? If you have the time and your surgeon is fiddling around with the cannulas, as they always do forever, then you can check your prime, take an ABG out of the prime and make an analysis, or from the RBCs if you get them. And you can add some sodium bicarbonate, some potassium, and so on. Of course, you add heparin anyways to make the prime more physiological. So, okay, now a 90-year-old TGA child, we have now done a buffering. We are now on 1 hour VA ECMO run. Now our blood gas looks quite nice. We have a pH of 7.3 where we want it, a PaO2 of 250, a good venous saturation, a post-oxy gas of 360. Can be relaxed, right? All looks good? Okay, you want to go to bed, you are exhausted. Then you get the call from the ICU. Listen, guys, it's 6 hours post-operatively, post-insertion of the ECMO. We have now blood from the ET tube. What should we do? What can it be? The saturation is still 100%. Do we have a problem here? Do we need to intervene? What can it be? Well, in ECMO, it's very easy. Almost always it can be bleeding. We have to deal with anticoagulation. But it can be also pulmonary edema, when you have frothy secretions coming out of the ET tube. And when we do see the X-ray 6 hours post-operatively, the situation becomes quite clear, even more so when we see this, what Roberto focused on earlier. Yeah, we have a very, very flat line here. We have basically no own cardiac output. We have a white X-ray, which shows you pulmonary edema because the aortic valve is not opening. And actually, if you have looked very close, you can already see initially that we have a problem, because if your post-oxy gas and your gas from the patient are so close together, then there's very, very little own contribution from the heart. Yeah. So in this case, we definitely waited quite long until the pulmonary edema showed up, when we already should see with this kind of arterial tracing, there is a problem. So what do we do? Everybody listen to Roberto. What do we do? Venting, exactly, of course. We do the same in the children, yeah? But of course we don't have impeller devices or small things like we have for the adults. So what we do, the only way it can be done is either you do a septectomy and then you have a hole in between the two atriums, or a little sucker like this is inserted in the left atrium or the left ventricle. And you see it's a tiny baby, it's a tiny cannula, which then comes here into the normal size of tubing, yeah? And we just heard about the importance of this venting. So your surgeon have inserted the vent, and they tell you, yeah, just make sure it stays open and you can monitor it. Not so easy with such a little red thing. You cannot really see the flow in it. So what can you do? Well, you can put a flow meter onto this area, which has the normal tubing size, and measure the flow you're getting through. And at least you see the trend. If the flow decreases, you may at least look closer for some clotting. And then you can have, if you have something like this on your ECMO devices, which measures the venous saturation and the arterial saturation on your ECMO circuit, you will have here on the venous line a very high venous saturation, because you get arterialized blood and venous blood together into the venous line. So it's actually artificially higher than the venous blood from your patient. So these are the two options. You can at least monitor a tiny bit that this little sucker stays open. So now, finally vented, yeah? Intensivist is leaning back, is all relaxed now. But the ECMologist thinks, you, the intensivist, everybody, the nurses, this room looks like this. So what can we do? The first question when you're on ECMO is you ask yourself, how do I get off again? Because we don't want to stay on ECMO forever. So what do we do for the weaning in children? We do it similar to the adults. We just try to reduce the flow on the ECMO machine. But the minimal flow to keep the circuit from clotting in those little devices or in these little machines is often 100 to 150 mils per minute. Yeah? And if you have a child which needs 300 mils per minute as a full flow, so to say, you can only wean down to 50%. So how can you really think or predict how to come off ECMO? And there are different approaches in the pediatric world how to do it. One approach is to use a bridge. And that works like I tried to illustrate here. You have a shortcutting from the arterial line back into the venous line, and then you can have a higher flow via your pump and your oxygenator, maintain a high flow inside here to avoid clotting, while you can you have a reduced flow to the patient, and you can see if the child comes or the heart is beating, there's no lactate elevation, you can do it for a longer time. Other approaches, which is also used, is clamping and unclamping the circuit. You clamp the circuit for 10 minutes, then you release to make sure that there's some circulation, then you clamp another 10 minutes. Tried it out too. I don't like this approach so much because it falses your results and it has a higher risk of clotting into the circuit. And the last thing I wanted to introduce to you is the pump-controlled retrograde trial off. So what's that? Well, here you see the normal ECMO flow, venous drainage, arterial return. If you do it, the opposite side, you drain via the arterial line. You use the pump as a resistance, you dial down no sweep gas, it's switched off, and you return to your right atrium. So you increase the right ventricular filling pressure and the venous return, actually a good thing. And with that, you also unload the left ventricle, you reduce the afterload and the systemic vascular resistance. Theoretically, not such a bad approach, but not many studies are published about this, and complications are really not investigated on this. So there's in 2017, Australian group reported a case series of 17 patients, pediatric patients, only with a duration of 15 minutes of the retrograde trial off to 2.5 hours. Or here in 2018, a Chinese group reported a case series of 7 adult patients. And I mean, you of all group of people should understand why this is probably not, I mean, theoretically a good approach, but do you want to really flush everything back? What is sitting on the oxys, all clots, they have filtered out and little air bubbles and so on. Do you really want to flush that back into your patient with a retrograde flow? I'm not so sure it's a very safe approach either, and it's not very widely adopted in the pediatric world yet. So the challenges on pediatric patients are the same as in adults: bleeding, clotting, hemolysis, inability to come off, circuit changes, oxygenator problems, time for reassessment, and so on and so forth. So in the limited amount of time I have, of course, I don't address them all. But now we go to the single ventricular patients, very interesting category. So we have this 11-days-old baby. She's 2.3 kilos, all girls today, with a pulmonary atresia. What is a pulmonary atresia? You see here on the picture. You have no connection from the right ventricle to the pulmonary arteries. The only way the pulmonary arteries are filled with blood are post-delivery, via a patent ductus arteriosus. And what we do in our days, either we stent this ductus or we put a BT shunt, which is a aorto or at least a subclavian connection to the pulmonary arteries to replace basically what the duct is doing. So until further notice, and you can go to the different stages of the single ventricular repair. Yeah, this is what we did for this child. We were very happy. We extubated her yesterday. During extubation, the nurses were all enthusiastic, cuddling the child. The central line fell out. Overnight, we had a problem. Lactate is a tiny bit elevated, comes up to 5.3. We are watching the child a bit closer. And early morning, the child arrests. After 5 minutes of no ROSC, we called for the ECMO team for ECMO initiation. And of course, during the resuscitation, also the arterial line falls out. So easy, fast central cannulation, 14 French venous arterial, 8 French arterial cannula, good flow achieved, low pressures on the ECMO circuit. This is how the circuit looks after initiation. And we still have no access to the child. The child looks very mottled, ice cold, cap gas to get is impossible. So 1 hour after ECMO initiation, we have a femoral line in and we get a blood gas off. Yeah, shows you this, a pH of 6.8, a base excess of -23 and a lactate of 29. And half an hour later, we have even an arterial line, which shows you even worsening blood gas. So what's the next step and what's the problem here? So we do a fast echocardiography, which shows basically no flow in the descending aorta. Yeah, the cannula, the arterial cannula, is too far directed here into the truncus, and all the blood is recirculating here via the BT shunt. Yeah, because the BT shunt was too big for a 2.3 kilo baby in the first place, but here we have a huge recirculation. So recirculation is not only a thing which happens in VV ECMO, but can happen in a VA ECMO patient here too. And it was not really clear here, but here you can already, I wanted to illustrate, you see here also, as you do in VV ECMO patients, that the color, there's no real color change, so there is a sort of recirculation. And for single ventricle patients, you often need higher flow because the flow is spreading in between the aorta and going into the BT shunt for the tissue oxygenation. And the oxygen deficit may persist if you don't increase the flows for the demand. And sometimes the only way to achieve an adequate systemic aortic flow is to reduce or clamp the BT shunt off. And there's more in this publication from 2016 explaining about the handling of the systemic pulmonary shunts. And here I just wanted to show you quickly one picture from a publication from me and my friend Peter, where we show the differences in between the single ventricular, where you have a BT shunt here. This is the BT shunt. Your aortic cannula comes from here, and the ECMO flow has to be distributed in the descending aorta back into the BT shunt, because that needs to stay open and and fill the pulmonary arteries, otherwise they will clot off, and a retrograde for the coronary arteries. This is why in BT shunt patients you often need higher flows than you normally expect by your normal calculation. But the other possibility is that you make RVPA conduit, which we call a sano shunt, from the right ventricle to the pulmonary arteries, in order to in order to perfuse the pulmonary arteries, not via BT shunt here, but via this conduit. Completely different in terms of the ECMO flow, because the ECMO flow remains the same here in all three directions. But if we unload too much the heart, there is no cardiac output here, and your sano shunt will clot off. So there you also, like with venting, you also have to make sure that there is a tiny bit of cardiac output. So you really have to know which kind of shunt your surgeon have put in to advise for the ECMO flow. Then for the next stage in a single ventricular repair, the superior vena cava is directly connected to the pulmonary arteries. If such a child needs to go on ECMO, where do we cannulate this child? Okay, so let's say we go classically, still right atrium, and return in the Demus K anastomosis here in the aorta. Okay, so this is how it looks. The vena cava superior is to the pulmonary arteries, right atrium, aorta. But what about this part? What about if the problem of this patient is an elevated pulmonary vascular resistance here? Then your child gets such a head because despite the drainage of here, if the pulmonary vascular resistance is too high, this flow cannot come out and is not drained. So you might end up needing to put a second cannula in this vena cava superior as well to have a double drainage from the right atrium and from the Glenn anastomosis in order to have a good drainage and a chance of recovery. And for Fontan patients, the third stage of single ventricular repair, it gets even more complicated. And often it's very difficult to cannulate them transthoracical because they have had so many surgeries, and one is very afraid with reopening that something happens to the conduit here, which they put in order to elongate the vena cava inferior and make a connection to the pulmonary arteries. So this is how the Fontan repair looks like. So you have cava superior, cava inferior connected to the pulmonary arteries directly, but no pumping chamber in between, nothing. So what do you do if we cannulate peripherally and we drain from here and from there, yeah? And we have a conduit in between there. We have the risk that this conduit will collapse and clot off, yeah? So maybe not the best approach. And this is why we have gone to also drain from the lower part and return on the upper part of the Fontan circulation to provide some blood flow or force some blood flow through the pulmonary arteries and give some oxygenated blood back there that also reduces the pulmonary artery pressures, if that has been your problem at the beginning. And if it gets really complicated, you have to have two circuits to achieve support, which I don't think it's a very promising approach. One circuit which is just supporting the pulmonary circulation, and one which is just supporting the systemic circulation. Very complicated and not very successful, these stories. Yeah. So in adults for congenital heart disease, just one word to them. We have new guidelines from the European Society in 2022 because it's becoming more and more important. We have more than 85% of the children with congenital heart diseases, all the cases I showed you, they survive now, and they will show up at your place even in adult cardiac surgery. So in summary, children who require ECMO need some special considerations. We have the same problems as in regular ECMO patients in terms of bleeding, clotting, and equipment failure. And anatomy and physiology of congenital hearts, specifically the single ventricles, are complicated and must be completely understood in order to achieve a good ECMO run. And the number of adults with congenital hearts are increasing, and you will be likely to encounter such patients during your career. Thank you very much for your attention.